breathe. So Dr. Iris Perez is an associate professor of clinical pediatrics and director of CCHS and diaphragm pacing programs at Children's Hospital Los Angeles. And she has vast experience, both research and clinical wise, in CCHS and home ventilation. And Dr. Thomas Keene is a professor of pediatrics, physiology, and biophysics. And it doesn't say here, but he is also a very good magician. And he's the director of cystic fibrosis program at CHLA at the moment, but he has a long research and clinical experience with CCHS and home ventilation program. And needless to say, Children's Hospital Los Angeles is the leading center in the world, both for diaphragm pacing and clinical excellence of care for children with congenital central hypoventilation syndrome. And I'm not biased, but I did do my training with Tom at Children's Hospital Los Angeles. So I may be a bit biased, but thank you for accepting. And please go ahead.
Okay, thank you so much, Rafika. So I do have to say a couple things. One, Rafika really was one of the most outstanding fellows that we have ever trained. And so when she wants to invite us to speak, I'm very honored because I know she can get anybody in the world. So thank you so much for your kind invitation. And secondly, I'm kind of the forerunner, if you will, for the major presenter who's going to be Dr. Iris Perez, who has been my associate for many years now. And for a while I was doing CCHS by myself, and I thought I need some help. And she graciously not only stepped up to the plate, but really has improved our program dramatically. A lot of the recent papers that have come out of our center really have been her idea. And perhaps more importantly, virtually all of those papers were done with either undergraduate students or medical students. So we're trying to get people young to get interested. So thank you again for the presentation. So we're all pediatricians. So I want to start with a fairy tale. So once upon a time, there was a mermaid named Ondine, perhaps here. And of course, Walt Disney popularized some of this myth, okay? So mermaids are immortal, and they are the daughters of Neptune, or Poseidon, the god of the sea, all right? Now, they lose their immortality if they fall in love with a mortal. And so as luck would have it, Ondine met a knight named Hans and fell in love with him, and they married. So she lost her immortality. But as time went on, Hans tired of Ondine and left her, jilted her for another woman. Now, Poseidon, or Neptune, is a powerful father-in-law to be reckoned with. So he put a curse on Hans that none of his automatic bodily functions would happen unless he consciously willed them. Okay, so you can see that they like this myth in Copenhagen. And so a play was actually written about this by a French, I can't pronounce it, Girardot? Girardot, okay. And it ends by saying, Ondine says, try to live, Hans, you too will forget. Hans says, try to live? That's easy to say, isn't it? If I relax my vigilance for one moment, I may forget to breathe. He died, they'll say, because he could no longer bother to breathe. Now, this is a poignant bedtime story for children like Evan, Amanda, Sarah, Matthew, Lindsay, Monique, Natasha, Garrett, Lauren, and Jennifer, who all look reasonably healthy when they're awake, but when they go to sleep, they need to be ventilated. So this really is what Ondine's curse is all about, or CCHS as we prefer to call it. So let's just review a little bit of physiology for a second. So Rafika knows that at Children's Hospital Los Angeles, we say that the respiratory system is not just the lungs, but in fact, ventilatory muscle power and central respiratory drive have to be adequate to overcome the respiratory load. So in normal individuals, both are more than adequate to overcome the respiratory load, which means the balance is tipped in this direction toward adequate ventilation. However, as in CCHS, if you have a decrease in central drive, then your balance might be more precariously positioned or even tipped into respiratory failure if central drive is inadequate to overcome the respiratory load. So this is the problem in CCHS, all right? This is defined as a failure of automatic control of breathing, characterized by hypoventilation and or hypoxia, which is worse during sleep than during wakefulness. And there's an absence of primary lung disease, heart disease, ventricular muscle weakness, neurologic or metabolic disease to explain this. We now know that this also is accompanied by other types of autonomic nervous system dysfunction, and it is a mutation of the FOX2B gene, which Dr. Perez is going to talk about in more detail. The paper that's most commonly referenced as the beginning of this is the one by Robert Mellons in 1970. However, I just do want to say, and I'm not going to brag so much about it that I showed a picture of, that actually here at Children's Hospital Los Angeles, Larry Fishman scooped Dr. Mellons by 5 years. And we have a publication out from 1965, originally describing what was also titled Ondine's Curse, but basically is CCHS. So a couple of things about this that are of interest. So this is a graph of transcutaneous CO2 over time in a 13-day-old girl who has CCHS. And so what you can see here is when she's awake, her CO2 looks okay. When she goes to sleep, it rises. The only thing that changed here was that she woke up and CO2 came back down, and then she goes to sleep again and goes up. Now, traditionally, this is the way we used to make the diagnosis before the gene was discovered, or the gene abnormality was discovered. So what we used to do is have medical students who were rotating on our service go to the ICU and sit there for, as you can see, 3 hours or so, and plot, every 3 to 5 minutes, their CO2, their oxygen, their heart rate, whether awake or asleep, to get these kind of graphs. So what I used to tell them is, now don't wimp out. Don't just let the CO2 go up to 50, because this is a diagnosis we're going to make that's going to affect this child for the rest of their life. So one eager medical student that we had took me seriously, and she called me here. I was up in my office. She said, the CO2 is 105. Is that high enough? I said, well, yeah, I'll be right down. So the only thing we did was wake this boy up. This is a different kid. Wake this boy up, and you can see his CO2 came back down to normal. He's not being ventilated here. He just was being awake. So this is a really unique pattern that, if you think about it, doesn't really occur in many other disorders. Now, many infants don't show this pattern. Many infants will hypoventilate both awake and asleep, and may, over time, get to the point where they mature to this pattern. So, what's going on? So this is a normal hypercapnic ventilatory response by the rebreathing method. And you all know that in normal individuals, if you increase PCO2, your minute ventilation increases in a linear fashion. You can see a very tight R value there. This is the same test in one of our patients with CCHS. And I think you can see that there really is no relationship between CO2 and minute ventilation here. Not a significant slope, all right? This was the original publication by Jimmy Payton and Soumya Swaminathan that looked at 5 children, and you can see again, minute ventilation plotted against CO2. There's no relationship here in any of these. None of these kids increased their ventilation. And by the way, these responses were tested during wakefulness. So we know that they don't breathe during sleep, but they also have absent responses during wakefulness. The same is true of hypoxia. So here, what's plotted is minute ventilation versus saturation. Ordinarily, ventilation should increase linearly as O2 saturation falls. And I think here you can see that there's no real relationship here. So the other thing that was notable when we did these tests on these children is they didn't care. I mean, they didn't subjectively, didn't know they were hypoxic, didn't know they had high CO2, and they really didn't care one way or the other. All right. So the problem then in CCHS, the big problem is that they have absent subjective and objective responses to both hypoxia and hypercapnia. Now, you've all learned with other disorders to identify respiratory failure or pneumonia or hypoxia in somebody as distress, agitation, tachypnea, retractions, nasal flaring, etc. All of these signs depend on intact ventilatory control. So these signs are all absent in patients with CCHS. Thus, they can be profoundly hypoxic, but may not show you clinical signs. So this is why non-invasive monitoring is extremely important, and training parents to look for subtle signs that there are problems going on. So basically, to summarize my portion, the problem with CCHS is that these patients don't breathe. They don't respond to hypercapnia, don't respond to hypoxia. So the treatment is that we need to breathe for them. So now I want to turn this over to my colleague, my boss, the director of our program, Dr. Iris Perez.
Okay. Thank you, Tom. It's really hard to follow when you to give a talk when you're following your mentor. So, so my portion is more on the clinical aspect, and we're going. Sorry, can you hear me, Rafika? Okay, so my portion of the talk is how to approach patients with suspected CCHS. And of course, we all know once we have someone we suspect as having CCHS, it's important to confirm the diagnosis with FOX2B gene mutation. And while awaiting for the test, it is imperative to also rule out the other causes of hypoventilation. We are all familiar now with this picture of the FOX2B gene. We know that the FOX2B encodes a highly conserved transcription factor that is important in the development of the autonomic nervous system. All mutations in the polyalanine repeat mutations are located within the second polyalanine stretch of exon 3, as seen in this slide. And most, if not all, of the non-polyalanine repeats are located in the 3 end of exon 2 or in exon 3, as seen here. The majority of patients with CCHS have mutation in the FOX2B gene have the polyalanine repeat mutations. The number of the alanine repeats on the affected allele are 24 to 33 range, and resulting in a genotype of 2024 to 2033. The normal alanine repeats, as we know, is 20 alanine repeats, producing a genotype of 2020 FOX2B. The most common genotypes are 2025, 2026, and 2027. About 9% of patients will have the non-polyalanine repeat mutation, and these mutations include the missense, nonsense, frame shift, stop codon mutations. And now we know that less than 1% of patients may have the FOX2B exon or whole gene deletion, and these patients have a variable phenotype. When requesting the FOX2B gene testing, it's crucial to know what the lab can do. The FOX2B screening test identifies all PARMs, exon 3 frame shift, NPARMs, and somatic mosaicism. The FOX2B sequencing test identifies all PARMs and all known NPARMs. And the multiplex ligation dependent probe amplification, and you have to say it in one breath, MLPA, identifies FOX2B deletion of exon 3 or whole FOX2B deletion. In general, patients with NPARMs have more severe phenotype, and thus they may require continuous ventilatory support, present with Hirschsprung's disease, and have tumors of neural crest compared to those who have PARMs. Patients with longer PARMs and NPARMs generally require full-time ventilatory support. The 2024, those with 2024 and 2025 PARMs have the hypoventilation unmasked, usually after exposure to respiratory depressants like undergoing general anesthesia or severe respiratory infection. Those with 2026 PARM generally requires ventilatory support during sleep, but they may also need ventilatory support during wakefulness, depending on their activity. And those with longer PARMs, like the 2027 and 2023, generally require full-time ventilatory support to live. And also, like earlier stated, those with NPARMs may require 24-hour ventilatory support. However, at our center, we have a group of patients, as you can see here, who have 2027, 2023, and NPARMs who have been able to breathe spontaneously during wakefulness and are only on assisted ventilation during sleep, as seen in this figure. As stated earlier, those with FOXO-B gene or exon deletion have variable phenotypes, and Jennings et al. Published in Pediatric Pulmonology in 2012 the presentations, which can range from hypoventilation with Hirschsprung's to apparent life-threatening event, hypoventilation during sleep, or need for full-time ventilatory support. Recently, we have started to recognize that patients with NPAR mutations have variable phenotypes. As seen here, we reported a family from 3 generations where 2 patients had ventilatory requirement during sleep, and the other 2 were asymptomatic without need for any ventilatory support. Other centers have already published their experiences, and in some patients, the patients required only supplemental oxygen, no support, or bilevel passive airway pressure support during sleep. In 2018, we reported our findings of the phenotypes of a group of patients who had non-polyalanine repeat mutations. And I am glad to say that our findings and our report have been accepted for publication at the Journal of Clinical Sleep Medicine. In collaboration with the team at Children's Hospital of Atlanta, we performed a retrospective study to describe the phenotype of patients with NPARMs. We included 8 patients in our study, and our data showed that all patients had signs of respiratory depression in the first 2 months of life. But we also found that out of the 8, only 1 patient required continuous ventilatory support, had Hirschsprung's and neural crest tumor. 5 of the patients required positive pressure ventilation only during sleep, and 2 of the 8 required oxygen only during sleep. So we know that CSHS is not only a problem with forgetting to breathe, but also involves autonomic nervous system dysfunction. CSHS patients are at risk for life-threatening sinus pauses of 3 seconds or more, particularly those with longer polyalanine repeats. We have a student from in undergraduate who is now a medical student who worked with us in a summer. And we looked at our cohort of 16 patients and found that 10 of the 16 patients that we have had sinus pauses of an average length of 3 to 4 seconds. In our cohort, syncope was present in half of them, and 5 of the 16 patients were symptomatic without significant sinus pauses. We also found in our group of patients that of the 10 patients who had sinus pauses greater than 3 seconds, 4 of the 10 were asymptomatic, and all of the 4 had FOX2B 2027 PARM. 2 patients also had 2025 PARM presented with syncope, and 1 of them had no sinus pause. In 1 patient with sinus pause, the presentation was dizziness and syncope. So as you can see here, 12 of the 16 patients had implantation of cardiac pacemakers, and 9 of the 12 had significant sinus pauses on ambulatory Holter monitoring, while 7 of the 12 patients were symptomatic. So we summarized that CCHS patients, regardless of FOX2B genotype, are at risk for life-threatening arrhythmias. Of these patients, syncope is the most common symptom. We found that some symptomatic patients do not have significant sinus pauses, but may still require cardiac pacemaker placement. Some patients are asymptomatic and have significant sinus pauses and would require cardiac pacemaker placement. And our findings support the ATS recommendations in 2010 that these patients should have yearly cardiac ambulatory monitoring regardless of genotype. Recently, we collaborated with our GI colleagues in looking at the GI presentations of our patients, particularly at the presence of motility disorders. In general, Hirschsprung's disease is found to occur in about 20% of patients with CCHS. In our cohort, we found a higher percentage of Hirschsprung's disease, which was 31%. And of these patients, majority had rectosigmoid involvement, and close to 1/3 had long segment involvement. In our group of patients, most had 2027 PARM, like others have reported, but 2 patients had 2025 PARM, and 1 of them had a more severe total colonic aganglionosis, thus suggesting that CCHS patients with constipation should be screened for HD regardless of genotype. Colonic myopathy was present in the residual segment of a treated Hirschsprung with refractory constipation, indicating their continued follow-up with the gastroenterologist or surgeon. We also found 1 patient with achalasia type 1 in our group. So, how do we take care of these patients from a ventilatory standpoint? CCHS is a lifelong disorder, and we know that weaning from ventilatory support is not realistic. Thus, it is vital to ensure optimal ventilation and oxygenation both during sleep and wakefulness so they can have normal activities, as this patient here playing golf. For most patients, oxygen supplementation is generally inadequate, but as we and others have shown, some without hypoventilation may do well with supplemental oxygen with vigilant monitoring. At present, there is no pharmacologic treatment that we know of that is available. At our center and in other centers, positive pressure ventilation via tracheostomy is the most common form of ventilatory support in those who are in the first years of their life. For those who require full-time ventilatory support, diaphragm pacing while awake can be a consideration. Although in other places, non-invasive ventilation by bilevel positive airway pressure by mask have been used in younger children at our center, we contemplate transition to non-invasive ventilation or diaphragm pacing in those children who are stable, a little bit older, around 6 years of age, and require ventilatory support only during sleep. For whatever type of ventilatory support we provide, we maintain end-tidal CO2 in the mid-30s, generally below 40, and oxygen saturation of 95% and above. So non-invasive positive pressure ventilation is provided by nasal or face mask and can be delivered by conventional bilevel PAP or by volume assured pressure support. Timed mode or spontaneous mode with appropriate backup rate is recommended. And at our center, we use the time mode to ensure mandatory breaths. As we know, these children do not increase their minute ventilation in response to hypercapnia or hypoxemia. And in the same thread, CPAP or BiPAP without rate are considered inadequate for patients with CCHS. The American Academy of Sleep Medicine has given us some guidelines on how to provide positive airway pressure in patients with alveolar hypoventilation. In those being started on NPPV for alveolar hypoventilation, the recommended starting pressure, IPAP, is 8 centimeters water, and the recommended EPAP is 4 centimeters water, with a maximum IPAP of 20 centimeters water in those who are less than 12 years of age, and 30 centimeters water in those who are 12 years of age, and maintaining a minimum pressure support of 4 centimeters water and a maximum pressure support of 20 centimeters water. The recommended settings for volume assured pressure support ventilation would be to obtain a target tidal volume of 8 ml per kilo of the ideal body weight, with a minimum EPAP of 4 centimeters water, minimum IPAP of 4 centimeters water above the EPAP, and a maximum IPAP of 25 to 30 centimeters water. So, how do we transition patients from positive pressure ventilation by trach to non-invasive positive pressure ventilation? There are several protocols that have been reported, but at Children's, this is how we do it. Patients have their tracheostomy capped during the day and are stable to breathe spontaneously with their tracheostomy capped. Then they undergo an airway evaluation to document airway patency. And at the same time, they get acclimatized to masks. So they get a mask fitting and provide some time to acclimatize. Once these are completed, and with the approval of our otolaryngologists, the patient will undergo an overnight polysomnography with the tracheostomy capped and ventilation provided by NPPV by mask. If this is passed and the decannulation is going to be in progress, at the time, the patient will be admitted for monitoring while ventilated with NPPV with trach capped. If they do that overnight, they do well, the cannulation is performed and the tape is placed over the stoma, and then the patient stays maybe another night or two for overnight monitoring to assess that they are adequately ventilated by NPPV by mask. So we do not start because of the risk of mid-phase hypoplasia. It's important that these patients will be closely monitored for skeletal facial abnormalities. We may want to refer them to the craniofacial team or plastic surgeon. And it's important to emphasize to the family that these children on non-invasive passive pressure ventilation may still require intubation during acute respiratory illnesses. So another form of ventilatory support is diaphragm pacing, where the patient's own diaphragm acts as the ventilatory pump. It allows freedom from the ventilator during the day in those who are full-time ventilator dependent. It permits tracheostomy decannulation for select stable patients requiring ventilation only during sleep. We all know that diaphragm pacing involves four components. One is the surgically implanted phrenic nerve electrode, a surgically implanted receiver, external antennas, and the external transmitter that generates electrical energy similar to radio frequency. So how does it work? The transmitter, as seen here, generates electrical energy similar to radio frequency. The energy is then transmitted from the antenna to the receiver, and the receiver converts energy to electrical current, and the electrical current is conducted to the phrenic nerve, stimulating the diaphragms. Therefore, it's important that these patients will have normal intact phrenic nerve and normal diaphragm muscle. So, who is not a candidate for diaphragm pacing? Patients with C3 to C5 spinal cord injury are not ideal because diaphragm pacing requires intact phrenic nerves and diaphragms. Those requiring MRI studies. And we have found in our studies that those who are overweight or obese will have problems and may not be successful with diaphragm pacing. Because with obesity, the increased distance between the antenna and the receiver resulting from large amounts of adipose tissue can result in inconsistent diaphragm contractions depending on the patient's position. Again, airway problems such as those as tracheomalacia may prevent a successful diaphragm pacing, particularly in those with diaphragm pacing without tracheostomy. So at our center, the surgery is performed thoracoscopically. You can see here the implanted electrode, and you can see that this is the phrenic nerve, and it sits on a groove in this electrode. And so there is no encircling of the phrenic nerve when the electrodes are surgically implanted. The perioperative period is a vulnerable time for CCHS patients because we are implanting what's considered a foreign body. Patients receive vancomycin for 24 hours to prevent infection. The diaphragm pacer equipment is checked during the surgery, so we ask our anesthesiologists that our patients do not receive neuromuscular blockade. And there's the risk of bradycardia and asystole due to their autonomic nervous system dysfunction. And because CNS depressants, general anesthesia, depressed ventilation in CCHS patients, we are acutely aware that they need to be ventilated throughout in the pre-procedure, in the operative procedure, as well as after. It takes about 3.5 hours for the diaphragm pacer surgery at our center. After the surgery, all patients are admitted from the OR to the intensive care unit for ventilator management. The mean length of stay at our center for our patients is about 4 days, and the average hospital stay is about 5 to 7 days. And complications that have been reported included pneumothorax, presence of atelectasis, and development of pneumonia. Because during the diaphragm pacers implantation surgery, the ventilation is by single lung ventilation. And so to prevent atelectasis and pneumonia, after the procedure, the tracheostomy tube is upsized and the patients are placed on bronchodilators for airways clearance. Seizure has been reported in one patient, and this was attributed to hypercarbia. After the surgery, we do not start diaphragm pacing right away. We wait about 6 to 8 weeks to allow for healing before we start pacing. So we start generally between 1 to 2 hours per day and then gradually increase. And it takes about 12 to 16 weeks to complete the diaphragm pacing use. So we looked at our patients who have been receiving diaphragm pacing without tracheostomy. We looked at 18 patients, and we found that 11 of the 15 were decannulated. By the way, this is a student who did her scholarly activity with us one summer, and this was her project. So what did we find? We found that the mean age at pacer implantation for our patients, they are a little bit older. It's 9.6 years plus or minus 6.4 years. The time from the pacer implantation to the initiation of pacing is about 2.8 months. The average time from pacing initiation to full-time nighttime pacing is 6.6 months. And the average time from diaphragm pacing pacer implantation to decannulation is 12.2 months, or about a year. Again, in this project, we found that obesity and airway malacia prevented successful decannulation, and that snoring and or obstructive apneas were present in some. So how did we choose our patients? It was important to us that we select our patients that we are going to consider for diaphragm pacing without tracheostomy. They should only require ventilatory support during sleep. They generally are older, so they're not taking daytime naps. They have a stable medical course requiring infrequent hospitalizations. And when they are sick with acute minor respiratory illnesses, they do not require full-time ventilatory support. And we emphasize that diaphragm pacing is not a secure method of ventilation, and intubation may be required for serious illnesses. So how do we transition patients for diaphragm pacing without tracheostomy? First, we establish that adequate ventilation is achieved with diaphragm pacing using an open tracheostomy for 3 months. If they do that, then they're scheduled for overnight polysomnography. Their tracheostomy tube is downsized. And during the sleep study, this is how we do it. So if the oxygen saturation is low, but the CO2 is normal, then patients may just need oxygen saturation with a tracheostomy count. If obstructive sleep apnea is present, then diaphragm pacer settings, particularly the tidal volume, are decreased during the study. If these are unsuccessful, then the patients are considered for tonsillectomy and adenoidectomy if necessary, or treat nasal allergies. And a repeat sleep study at the appropriate time is scheduled. If oxygen saturation is normal and the CO2 is below 40 and there is no obstructive sleep apnea, then our ENT colleagues will do an airway evaluation again, and if normal, proceed to decannulation. These patients stay overnight after decannulation for gas exchange monitoring. So how does diaphragm pacing confer OSA in patients with CCHS? So in normal individuals breathing spontaneously, there is a synchronous contraction of the upper airway skeletal muscles with diaphragm contraction to maintain airway patency. However, with diaphragm pacing, the synchronous contraction is bypassed, predisposing to upper airway collapse due to the negative intrathoracic pressure created by the diaphragm contraction. We had another student who is seen here in the picture who looked at polysomnograms of patients ventilated by diaphragm pacing without tracheostomy. Of note, at that time, the risk of OSA precluded decannulation for these patients in some centers. What we found was that although OSA occurred in patients with CCHS ventilated by diaphragm pacing without tracheostomy, making changes in the amplitude can lessen the upper airway obstruction without compromising gas exchange. Of note, this student won many awards, including the ATS Abstract Award in 2015 in Denver, Colorado, as you can see here. As seen in this figure, by decreasing the pacer amplitudes or voltages, the AHI decreased, the oxygen saturation increased, and the end-tidal CO2 decreased to normal. So, in addition to adjustment of the pacer settings, we also make sure that our patients with nasal allergies are treated, and in those with tonsils and adenoids will undergo an adenotonsillectomy. In 2019, a study was published of 3 children aged 3 to 4 years at the time of the decannulation who were found to have overt upper airway obstruction with the use of diaphragm pacing. These children had pre-decannulation interventions, including the adenotonsillectomy. Of note, in addition to being younger compared to our cohort, 2 of the patients did not have airway evaluation prior to decannulation, and 1 had anterior tracheal wall collapse requiring airway reconstruction with costal cartilage graft prior to decannulation. Thus, this paper and ours emphasize the importance of selecting the patients properly. Hello. Selecting the patients properly, having the patients a little bit older, and the vital role of airway evaluation prior to decannulation. So are there any malfunctions associated with diaphragm pacers? Yes, they do have. We presented our findings at the Virtual Sleep 2020. And in this study, we found that close to half of our patients had at least 1 surgical revision. The malfunctions involve defective receiver, insulation leak, defective electrodes, and hardware infections. And most patients had defective receiver requiring receiver replacement. 10 of the 12 malfunctions had successful revision, and the average time from implantation to the malfunction was 3.8 plus or minus 3.5 years. For our patients, we see them at least every 3 to 4 months. During each visit, we monitor their CO2, we monitor their oxygen saturations. They undergo periodic polysomnography to adjust the ventilator settings. And during the polysomnography, it's important that we monitor their CO2, and they need regular visits with their otolaryngologists. So this is an example of a polysomnogram of a patient who was ventilated by diaphragm pacing. You can see here the end-tidal CO2s in the 40s. You can see that there is no airway obstruction, and the oxygen saturation was a little bit on the low side, but I would like to point out these diaphragm pacer artifacts that are seen here. Recently, we looked at we conducted a survey of patients aged 0 to 17 years. The survey is anonymous by REDCap, and we wanted to see whether these patients' sleep were disrupted either by their ventilatory support or other treatments at night. Our preliminary findings was presented at the 2020 virtual sleep meeting, and we found that most CCHS patients reported rarely waking up to their ventilator or monitoring alarms, as seen in this figure. Of the participants, only 9 reported receiving nursing at night, raising a possible safety concern for these patients, particularly those who are contemplating to live independently. Thus, based on our findings as well, we have instituted some changes in our practice. We have asked the question, do our patients not wake up because they may not hear the alarms? Therefore, now it's part of our practice to ask about their hearing evaluation, and if they haven't had hearing evaluations, make sure that they have an audiology referral. This paper has been submitted for publication. So this is a summary of our approach to our children who are presenting with signs and symptoms or who are suspected of having CCHS. And I would like to point out the last leg in the management of these patients. As early as 2002, we have shown that although de novo germline mutations cause majority of cases, CCHS has an autosomal dominant pattern of inheritance. And a shout out to Dr. Rafika for being a part of this project. Our other case reports have supported the autosomal dominant pattern of inheritance. And most recently, we surveyed women with CCHS and asked about their experiences. And what is an essential finding? One of the key findings is that prenatal testing is important and beneficial. In the women that we surveyed, all who were offered prenatal testing chose to undergo the testing by amniocentesis. And those who underwent testing, they said that the result did not affect their decision to carry or terminate pregnancy. And they viewed their test favorably and found it beneficial and were motivated by their desire to anticipate neonatal care needs. By the way, this is Dr. Maloney, who has published several papers with us and who has graduated, and she was the principal investigator for this project. We first discharged our patient with CCHS on home mechanical ventilation in 1977. And since that time, our knowledge of CCHS has increased exponentially, and emergence of new information has shaped our practice. We no longer use this type of ventilator, and CHLA has now a new look, which is seen in this slide. And what have we learned over the past 4 decades? It's important to have a high index of suspicion to diagnose CCHS early and to provide early treatment. FOX2B gene testing is required to confirm the diagnosis, but we must be aware of the type of the test being performed. There is variability in presentation, even in those with longer palms and palm. Thus, management needs to be individualized. And last, the importance of parental testing, even if those who are asymptomatic, cannot be overemphasized. So this is the end of my talk, and thank you again for inviting me.
Thank you very much to both. This was a really wonderful session on all you need to know about CCHS. So I will now hand over to Bilan to handle any questions to see if in the chat. I don't see any, Bilan, do you? Okay, so, okay, Bilan, you're muted. Do you want to go ahead and take questions?
Yeah, okay, sorry. Thank you for this excellent talk, really. It was great. And before starting the questions, I would like to announce that we had participants from 15 countries from 4 continents. So it was a great success. Thank you very much for you and all the participants from these countries. There's a question from our president of the society, Fazilet Karakoç. She asks, is there a suggested duration for renewal of the diaphragm pacer, even if there is no malfunction?
Tom?
I didn't really hear the question.
Yes, sorry.
Is there a suggested duration for renewal of the diaphragm pacer, even if there is no malfunction?
Oh, do you want to answer or do you want me to, Iris?
You can answer.
Okay. So, yeah, there is dysfunction of the pacers that occur, and sometimes it is at the level of the phrenic nerve electrode. The problem with trying to remove that is that there's a lot of scar tissue that forms around the electrode. And I think it's potentially very dangerous to try to do that because of the risk of damaging the phrenic nerve. So we actually just leave it in. We cut the lead wires off. There's actually no reason to remove it. It doesn't cause any harm. And if necessary, we'll put a second electrode, usually closer to the diaphragm if possible to do that. And we've actually done that several times. It's worked out very well. But I really would advise against trying to take off the phrenic nerve electrode, just because it's wrapped up in so much scar tissue that I don't think there's a way you could do it without damaging the nerve.
So maybe if I can just comment on Fazil's question, because we have this patient that we have transferred from non-invasive ventilation to diaphragmatic pace, and we didn't do a tracheostomy. I think at that time I talked to you guys a lot with your guidance, and she still continues to use it. Now it's been, I think, more than 8 years that she's been using it, and it has, like, she doesn't have any current problems, but we're always nervous, like, you know, when it's gonna fail or if something's gonna happen. So the current practice is not, don't touch it if it's not broken, I suppose, right? Okay.
Yep.
Thanks.
It's working.
Thank you. Another question from Tuba from Ankara. She thanks you for this nice presentation. Due to hypoventilation and hypoxia, neurological disorders can occur, especially in undiagnosed younger babies. How can we exclude the underlying neurological disease in these patients, she asks?
So if I understand correctly, we still, how can we exclude or?
Yeah, exclude.
exclude. So even for, so it is still our practice that once we send out the FOX2B gene mutation, while we are waiting, we still um, go over the rule out other conditions that could cause this hypoventilation. And some patients do. We have had patients who have presented with seizures, but they are followed closely by our neurologists as well. But in these patients, we think that if they are ventilated well, that they do well eventually. As you know, at our center, we do choose the best setting we think that provides the best ventilation awake and asleep. And we do it by hyperventilating them a little bit at night. So that's why our CO2s are in the mid 30s and definitely below 40s. I hope that answers your question.
Is there any question? You can just raise your hand and you can ask the question directly by yourself. We are, it's okay now.
So I have a question. I currently follow a baby who's like now 3 kilos, only a couple of weeks off, but very likely CCHS, normal ventilation when awake, hypercapnia when asleep. And neonatologists still think that like it's a breathing immaturity and like somehow miraculously will do better. So they keep trying during naps, oximetry and room air. But and we did send the FOX2B. The baby is stable now on a non-invasive ventilation. But the plan is, to get the FOX2B results, and then if it's confirmed, then do a sleep study and then do a tracheostomy and ventilator. But there are some reports, of course, with non-invasive ventilation, even in the very early period neonatal without a tracheostomy. It's a bit harder when they're extubated, right? Like the baby is already extubated and doing well on non-invasive, but it's a bit, of course, unnerving as this baby is, sleep for longer times, may get sick, may need intubation. So that would still, like, our decision was to go with the trach, but would that still be your decision as well at this time?
Yes, in patients with confirmed CCHS by FOX2B gene mutation and who do manifest the hypoventilation or in a lot of central sleep apneas, that would be our decision. The one that we described in our patient with NPARM had very, 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 very mild central sleep apnea, like a central sleep apnea index of just around 5 and just oxygen, just hypoxemia without hypoventilation. So we followed the patient very, very closely. Tom?
Sorry. Yeah, actually, one of the patients that we have who originally we did not document hypoventilation on polysomnography, and it looked like that child might do well with just oxygen alone. Interestingly, as that child aged, she actually developed hypoventilation, and the child, because by the time that happened, we could use non-invasive positive pressure ventilation. We are currently using that, and I think the child is doing better. Iris didn't mention it, but there are, I talked about the fact that these children do not manifest signs and symptoms of hypoxia and hypercapnia. So these kids can be missed. Some of these kids, especially the milder ones, 2025s, for example, can look normal. And of course, we don't normally do blood gases on babies, so they can go home. And in fact, the patient I just saw today, this morning before this conference, was diagnosed at 6 years of age, okay? The family was on vacation in Hawaii, and he developed appendicitis. They were not even on Oahu, they were on an outer island somewhere. And after surgery, this kid did not breathe after anesthesia. Interestingly, the anesthesiologist said, I think I've seen this before, and suggested to the family that they go to a CCHS center and get the kid evaluated. And in fact, he turned out to be at 2025. He's currently on BiPAP, doing fine with that. But he does have some subtle neurologic findings. So, you know, he obviously was not ventilated for the first 6 years of his life, but I'm sure experienced some hypoxia that resulted in not major but subtle sorts of problems. And if you talk to him, you can kind of detect that a little bit. So in general, our preference is, once this diagnosis is made, to kind of jump on it and ventilate them. But kids that present a little older, that don't have CO2, elevated CO2 on polysomnography, it's sometimes hard to convince the parents to do that. But I would agree with Iris that these are the ones that cause us to lose sleep at night, because I think, at least in the case of the one patient we had, she did progress to the point of needing it.
And we did do every 6 months of polysomnography.
Yeah.
With that
I mean,
patient.
this baby already has hypoventilation, so which is corrected with the non-invasive. It's just a matter of, like, you know, this little 5-week-old baby to have a tracheostomy or non-invasive support. But I think it's just tracheostomy is a better choice at this time. I think there's another question from Joanna.
Rafika,
Yes,
una
go ahead.
minute. Yeah.
Go
Yes.
ahead.
Yes, Rafika. Thanks a lot for your nice presentations, first of all. And then I wanted to ask you about your experience with the neural crest tumors. Do you perform abdominal ultrasounds and maybe urinary catecholamines usually, maybe in your follow-up?
Well, I can answer that, but we do not, we ask for symptoms, but we do not you know, based on the genotype, we then do not regularly do the catecholamines, but we do periodically do as symptoms and the abdominal imaging. But then, what type of abdominal imaging is the best? You know, is the question. What type of abdominal are you going to have these patients do MRI or ultrasounds every year as recommended? That's the hard part.
Yeah, I think it's safe to say we're still struggling with which test to do and how often to do it. Though one of the patients that I have had a ganglion neuroma, which fortunately was benign, which actually was first detected in the mediastinum. And then because she had one tumor, we did like a full body CT, and she had another one in the adrenal. They were both removed. They were both benign. She's not had any recurrence. I have another patient who actually developed an intra-abdominal neuroblastoma, and it was also a ganglioneuroma that was picked up by symptoms. So he started to have intestinal symptoms with abdominal pain, and that's how that was picked up. I have to tell you, we haven't really detected any unroutine screening at this point in time.
We do the abdominal ultrasound every year, but at the same time we used to do urinary catecholamines. Our patient had a abdominal neuroblastoma at 2 years of age, even if she had 2025 polyalanine mutation. So we didn't expect it. We used to do like this, and so I wanted to know your experience. about that. Thanks a lot.
Thank you. So up to what age do you do the abdominal ultrasound?
In every follow-up, we see the patients, and in the first 3 years, we see them every 4-6 months. After 3 years, if they are stable, once per year.
So just to add, so my patient with the 2 ganglioneuromas, we picked that up at about 5 years of age. The other young man actually developed his at about 25 years of age or so, somewhere in that ballpark. So I'm not sure there's an upper age limit. On the other hand, it's still pretty infrequent in our group, and I'm not sure that yearly is worth it. But like I said, we don't, actually, if any of you are wiser than we are, we'd accept your recommendations. But,
Yeah.
But we're still not quite consistent at the moment.
Yes.
I have a question before. Oh, sorry. Do you transition those patients maybe after your comment? Transition them to adults, like adult care, or you continue to care for them?
Oh, that is a good question, Rafika. We have been trying to transition them. But I think Dr. Keynes is finally making headway with the group in San Diego. We have been trying. They still come to us.
We're still following. Our first patient is 43. And our 38-year-old needs her diaphragm paces replaced. And so I'm leaving that to the surgeons. I think they're probably going to approve it, but a 38-year-old in a children's hospital isn't always looked at well, let's put it that way. Part of the problem is we don't really have anyone else in California doing diaphragm pacing in anybody, adults or children. So we've kind of created a monster in that there's no place else for our patients to go. We, I think, need to try and make an effort again to see if we can get the USC adult pulmonologist to agree to this, but previously they have not. So
yes, we're trying to make headway. We give talks to our adult colleagues, just doing a polysomnography with end-tidal CO2 monitoring, but we are taking baby steps. Everything is sleep apnea at this point.
This just goes to prove that pediatricians really are smarter than internists. And all of you were wise to go into pediatrics instead of internal medicine.
Goes without saying. I think there's one more question, Bülent. From Tuba.
And
So
she asks whether did you have any complication like pneumomediastinum when transition from tracheostomy to non-invasive ventilation?
We're lucky, none yet. It's a transition from NPPV to from PPV to NPPV.
Yeah, I think that's been pretty easy in our experience. It hasn't really been an issue. I don't think we've had a problem. We've transitioned a number of kids, and it's gone smoothly.
So is your transition age usually around 6 or later, during a little bit more adolescent?
Generally a little bit older, but like you, Rafika, I've been approached by several parents of wanting their children to transition to NPPV. So I'm actually working up one now. He's 6 years old, going to school soon. And so the way this process is similar to what I talked about. But in addition to that, I'm still a little bit worried about putting a mask in a patient whose face is still growing. So in addition to the usual, just a transition, I've also referred this patient to craniofacial just to get a baseline of how the kid is going to do, and they will work very closely with the otolaryngologist who is also at our center.
Okay, thank you.
So yes, 6 years old.
So Joanna works in Bambino Gesù in Rome. So they have a very good, they have a really excellent center there that I had a chance to visit. They have they also published a lot in CCHS.
I've read.
So what's your experience, Joanna? Like, do you transition kids usually from tracheostomy to non-invasive? Do you have a favorite age?
We published once with a colleague from Belgrado, and my first experience was with an adolescent, and I decided just to start before, because it was not a good idea, because we had the problem with the transition to non-invasive ventilation and then adolescents problems. Then we made it with two girls of 10 and 11 years old, and everything was okay. Once one of the girl had to perform adenoidectomy before the transition, but everything is okay. And then we are performing with the two girls from 7 and 8 years old. I think that time is decided by the patient and the family. I mean, they have to ask us to do that, because we are okay with the invasive ventilation. We are okay that when they ventilate in the correct way. So it's not our interest to change. We say it's possible to do. They have to ask us, and then we perform this transition, which is a period of great work for the baby, for the family, and for us, because we must perform it perfectly. It's a way we can go back, so we must be sure of every passage. And so I think that we don't have a correct time. We expect the answer, the question, and then we work.
Maybe one of the last question from Dr. Safa Dawood. What about routine ophthalmological assessment for CCHS? Is it mandatory?
Yes, we do. I think it's in our flow chart that we do send our patients to ophthalmology, just to make sure that some actually, I've had one patient who they say they're seeing an eye doctor, but but then started to read so close. So those are not only asking questions, but we do routinely send them. And then the ophthalmologist will say, see you back in 5 years.
We've seen strabismus in a number of these kids. Of course, we can diagnose that, but we can't fix it, but we still send them to the eye doctor.
Yes, we still send them.
I think that's about it for questions.
Yeah.
Thank you. And Bülent, do you want to close the session?
I just want to thank you all, and Rafika also thank you very much for organizing this talk with the world stars. And also I would like to thank everyone, and also one of the participants from Chile, Dr. Susana Soto, is always with us, and also I also thank her as well. And also many friends from Indonesia, India, Kazakhstan, Kyrgyzstan could not attend because it's too late. It's at midnight there.
Aww.
So they will watch the recorded links. I will share the links. So, and really, I'm very grateful to you all, and see you in our next meetings. We will also announce these meetings. Thank you very much.
Thank you very much for inviting us. Thank you.
Thank you.
Thank you.
Iris.
Bye-bye.
Bye.
Bye.
Bye. Bye, everybody.